Assalamu alaikum. Our lecture today is about acute gastroenteritis. This is the first part of two lectures with the same title, acute gastroenteritis. It's a very important subject. In this lecture, we are going to know the definition of diarrhea and the types of diarrhea. We're going to learn the most common causative agents that causing diarrhea or acute diarrhea in childhood, the differential diagnosis of diarrhea. We are going to learn how to assess the degree of dehydration in a patient presented with diarrhea, and to classify the dehydration into either isotonic, hypertonic, or hypotonic dehydration. Also, we are going to know the most common complications of diarrhea, and finally, what investigation that we have to send in a patient presented with acute gastroenteritis. The definition of acute gastroenteritis, it is defined as the process of malabsorption or increased secretion of a fluid and electrolyte, which will lead to increased frequency, volume, fluidity of the stool apart from normal. Some define diarrhea as sudden onset of excessive loose stool more than 10 cc per kg per day in infant, or more than 200 grams per 24 hour in an older children. Persistent diarrhea is defined as an episode of diarrhea that begins acutely. However, it lasts for 14 days or more. It has a high case fatality rate, up to 60%. Diarrheal disorders in childhood account for a larger proportion of childhood death. It is the second most common cause of child death worldwide. In addition to the risk of mortality, persistently high rate of diarrhea, especially prolonged and persistent diarrhea among young children, may be associated with long-term adverse outcome. Gastroenteritis is the result of infection that's acquired through fecal-oral route or by ingestion of contaminated food or water. The most common organism that cause gastroenteritis is viruses. Viruses responsible for up to 50% of all cases of gastroenteritis in the summer, and a higher percent, up to 80% in the winter times. Rotavirus infection is the most common identifiable viral cause of gastroenteritis in all children. Other viruses that may cause gastroenteritis is astrovirus, calicivirus, and adenovirus. In addition to virus, bacteria can cause acute gastroenteritis in pediatric age group. We can put E. coli at the top of the list with all its subtypes. Also Campylobacter jejuni, Clostridium difficile, Salmonella, and in case of watery diarrhea, we think of cholera and so on. In addition to bacterial and viral causes, gastroenteritis can be caused by parasites. For example, if the patient have bloody diarrhea, we think of amoebic dysentery, which is caused by Entamoeba histolytica. And on the other hand, if the patient have watery stool with gaseousness, we think of giardiasis. That's caused by Giardia limberia. According to the mechanism of diarrhea, we can divide the diarrhea into two types. It is either secretory or osmotic diarrhea. Secretory diarrhea occur when the mucosa of the intestine directly actively secrete fluid and electrolyte into the stool. Classic example of the secretory diarrhea is cholera. In cholera, diarrhea is stimulated by the enterotoxin of the Vibrio cholerae. The toxin will cause increased level of cyclic AMP within the enterocyte, which will lead to secretion into the small bowel lumen. On the other hand, osmotic diarrhea it occurs after malabsorption of ingested substances. This will ferment and will lead to pull water into the lumen of the bowel. Classic example of osmotic diarrhea is lactose intolerance. Also, non-absorbable laxative such as polyethylene glycol, magnesium hydroxide, milk of magnesia, which is also other example of osmotic diarrhea. In order to differentiate between the causes of diarrhea, we can divide the patient to either having osmotic diarrhea or secretory diarrhea. This depends mainly on the characteristic of the stool. If the electrolyte in the stool, mainly the sodium, is less than 70 milliequivalent, this goes with osmotic diarrhea. While it's more than 70, goes with secretory diarrhea. Also, the pH of the stool. If it is low, this means that this is mostly on osmotic diarrhea, while more than 6 goes with secretory diarrhea. Presence of reducing substance in the stool highly suggests presence of osmotic diarrhea, while negative reducing substance goes with secretory diarrhea. Also, the volume of the stool. Secretory diarrhea mainly characterized by large volume of the stool, it's more than 200 cc per day, while patients with osmotic diarrhea usually have a small volume of the stool, less than 200 cc per day. In addition to the knowing the constituents of the stool, we can also divide the patient to osmotic and secretory diarrhea by a simple clinical method. We can stop all feeding and oral intake and observe the response to that. This is done only in a hospital setting in a patient who is receiving IV fluid in order to prevent development of dehydration. When we put the patient after stopping all feeding, if the diarrhea stops completely, this is mostly goes with osmotic diarrhea. However, patients with secretory diarrhea usually tend to have continuous diarrhea even if all feeding had been stopped. Now we're going to speak about the clinical manifestation of acute gastroenteritis. Patients with acute gastroenteritis tend to have diarrhea plus systemic finding such as fever, lethargy, and abdominal pain. In case of viral diarrhea, the stool of the patient tends to be watery with no blood or mucus in it. Vomiting may or may not be present, and the dehydration is usually prominent. Fever can be present, and if it is present, they usually tend to be of low grade. Second, the patient may have dysentery. When the diarrhea or process of the inflammation is involving the colon and the rectum, the patient will have blood and mucus in the stool. Usually the stool is full smelling and the patient will having fever. An example of pathogen that causing dysentery is Shigella, also Entamoeba histolytica, Campylobacter jejuni, E. coli of enteroinvasive E. coli and enterohemorrhagic E. coli, also Yersinia and non-typhoidal Salmonella. Enterotoxigenic disease. Enterotoxigenic diseases are caused by bacteria that are capable of producing enterotoxin. For example, cholera and enterotoxigenic E. coli. The disease here is characterized by absent or low-grade fever, and it's usually involving the ileum. The patient will pass a watery stool that does not contain blood or mucus. The disease is usually of short duration. It lasts up to 4 days, and the patient pass about 4 to 5 loose bowel motion per day. The differential diagnosis of acute gastroenteritis. There are so many conditions that may be present in a way that's similar to presentation of acute gastroenteritis. It could be a condition that causing systemic infections, like patient who having septicemia or meningitis, or if the patient having local infections outside the GIT, for example, patient developing respiratory tract infection, otitis media, and UTI. All those patients may having loose bowel stool. Patients with surgical diseases like pyloric stenosis, intussusception, necrotizing, those may having vomiting and may be mistaken initially for acute gastroenteritis. Also, endocrine disorder, metabolic disorder, like patient with diabetes, when he developed diabetic ketoacidosis, also may be mistaken for acute gastroenteritis. When we are dealing with a child who developing diarrhea, our main consideration is to assess and treat the degree of dehydration. The degree of dehydration that the patient develop, it will lead us to the urgency of the situation and the volume of the fluid that is needed for rehydration of the patient. Firstly, we have to assess our patient for the degree of dehydration. We usually divide the patient into either having no sign of dehydration or having some sign of dehydration or to developing severe dehydration. We have 3 plans of treatment. Plan A, on examination, the patient will be well alert, normal eye, the tears will be present, the mouth and tongue is moist, and he's drink normally and if not thirsty. This patient usually divided or categorized as having no sign of dehydration, and we will use for him plan A for treatment. While patient with some dehydration usually develop some sort of restlessness, irritability, the eye will be sunken and tear is absent, the mouth and tongue will be dry, he's thirsty and drink eagerly. Those patients, usually we follow a plan B for treatment. Patient who is developing severe dehydration usually will be lethargic or unconscious. The eye will be very sunken, the tears absent, the mouth and tongue is very dry, And when we offer to him a glass of water, he usually drink poorly or not able to drink. Those patients usually follow a plan C for treatment. This table shows the clinical way of assessing the degree of dehydration. In order to assess the patient to having no dehydration or some dehydration or having severe dehydration, we have to examine firstly general condition of the patient. As patient with no dehydration, he will be alert. Those with some dehydration will be irritable and will be lethargic and unconscious in case of severe dehydration. The eye will be normal in no dehydration, while it will be sunken in some dehydration and severely sunken with severe dehydration. The tears are present in no dehydration, while it will be absent in some and severe dehydration. And we have to examine the mouth, specifically for the tongue, if there is presence of moistness. In no dehydration, the tongue will be moist. In some dehydration and severe dehydration, it will be dry. Then we ask the mother regarding the thirst. The child will drink normally in no dehydration, while he will be eagerly to drink in some dehydration, and patient with severe dehydration, he will be unable to drink. Lastly, we have to examine skin turgor. When we take a pinch of skin, it will goes back quickly in no dehydration and slowly in some dehydration and very slowly in a child with severe dehydration. The most important step in the management of any child presented with dehydration is to assess the degree of dehydration. We have to classify the patient whether he have mild, moderate, or severe dehydration. It's important for you to know that when we say that the child is mildly dehydrated or 5% dehydration, that means he lost 5% of total body weight. The most accurate way of estimation of degree of dehydration is based on the difference between the pre-morbid body weight and the current body weight. For example, when a child whose weight is 10 kg and now presented with dehydration and his body weight is 9.5 kg, that means he is 5% dehydrated, and it means that he lost 500 cc of total water. In general, we have three types of dehydration: either isotonic dehydration, or hyponatremic dehydration, or hypernatremic dehydration. Isotonic dehydration. It is the most common types of all types of dehydration, constitute about 70% of all types. It is occur when the net loss of water and sodium is the same proportion to that found in the normal extracellular fluid. Hypernatremic dehydration is less frequent type of dehydration. However, it is more dangerous type. It is associated with serious neurological damage. It usually occurs secondary to movement of water from the cells of the brain into the more hypertonic extracellular fluid. That will result in the shrinkage of the brain cell and tearing of the blood vessels within the brain. It is seen when the sodium loss is less than water loss. An example of hypernatremic dehydration is seen when oral homemade electrolyte solution is being used that contain high concentration of salt. Hyponatremic dehydration. This type of dehydration is seen in up to about 15% of all patients with diarrhea. It occurs as a result of losing large amount of electrolyte, especially sodium, in the stool. Those patients typically seen in an older infant and children with gastrointestinal infection who have been given fluid with low sodium content such as water, juice, soda, or tea. In addition, there is antidiuretic hormone is often released, which will further diluting the intravascular volume with reabsorption of water. In this type of dehydration, as the serum osmolarity will be full, the fluid will be shifted from the extracellular to the intracellular space, which will cause earlier and more severe intravascular compromise. Those patients usually require an immediate volume resuscitation in order to maintain the intravascular volume. This table will summarize the finding that we see in three types of dehydration. As we said that dehydration can be divided into three types according to the serum osmolarity or the tonicity. Either the patient have isotonic dehydration when we have normal serum sodium and normal serum osmolarity. Those patients usually will be presented with the typical signs and symptoms of dehydration. Patient with hypertonic dehydration who's having elevated serum sodium with elevated serum osmolarity, those patients, in addition to the typical signs of dehydration, they will have a sign of hypertonia, hyperreflexia, and it's very important to notice that those patients usually the urine output will be preserved longer than other types of dehydration. And when we examine for skin turgor, we will find a dewy abdomen and also they will having a woody tongue. Lastly, in patients with hypotonic dehydration with having low serum sodium and low serum osmolarity, those patients will be lethargic and sometimes will be developing convulsions, although infrequently. Usually, patient with hypernatremic dehydration, the degree of dehydration would be underestimated. That is because that water will be moved from the intracellular space to the extracellular space, which will result in the preservation of the intravascular volume. Complications of gastroenteritis. Firstly, and the most serious one is dehydration. Patient may develop metabolic acidosis, shock, and acute renal failure. Second is electrolyte disturbance. Also, the patient may develop hypokalemia with its consequences and hypernatremia or hyponatremia. Patient can develop seizure. There are so many reasons that the patient can develop seizure in a patient with gastroenteritis. It could be due to the electrolyte disturbance, for example, hyper or hyponatremia. Fever, the patient may develop febrile convulsion. Also, hypoglycemia due to the fasting or glycogen mass is small in children. The patient can develop seizure from hypocalcemia. Also, it could be an effect of toxin, like Shigella. Also, it may be a prodromal disease of CNS infection like meningitis. The patient can develop hemolytic uremic syndrome, which is a syndrome of microangiopathic hemolytic anemia, thrombocytopenia, and renal failure. It is seen due to infection with enterohemorrhagic E. coli. Lastly, the patient can develop what's called a post-acute gastroenteritis syndrome or a persistent diarrhea. This could be due to either a secondary lactose deficiency, or the patient may have intolerance to cow's milk, or it could be due to persistent infection. Now, how can we evaluate a patient who presented with gastroenteritis? Firstly, we have to examine the stool. The stool should be examined macroscopically for the presence of the mucus and blood. Also, microscopical examination of the stool for the presence of RBC, white BC, which will indicate colitis. If the general stool examination were negative for presence of RBC or white BC, then we have to think of viral etiology. We have a rapid diagnostic test for the presence of rotavirus in the stool. We should also think about it, especially during a winter season. Sometimes we have to do a stool culture, especially if the patient presented with fever, profuse diarrhea, dehydration, bloody diarrhea. Also, if we suspect an organism that requires antibiotic therapy, or if the patient develops hemolytic uremic syndrome. In addition to the stool examination, some blood tests are required, for example, serum electrolyte, renal function test, and complete blood count. A urine examination are sometimes required, especially if we are thinking of UTI. When UTI is suspected, then we should send the urine for culture and sensitivity. It is uncommonly to have positive blood culture with bacterial enteritis. However, there are some exceptions. For example, patient with typhoid fever